Okay, thank you very much. So we switch the session. Approach to imaging will be later, and now will be the osteoporosis. I have 20 minutes. I'll try to finish early. If I don't, I'll cut myself and for the next speaker. So osteoporosis is a very common problem that we encounter in family practice, in internal medicine, orthopedics, neurosurgery, wherever you see. So I just wanted to start with the pathology, with the physiology and normal status of the bone, and then move on next to the real pathology, which is osteoporosis. So bone structure, we have the trabecular bone. There is a trabecular, there is a cortical bone. The properties of the trabecular bone, is there is here, right? Oh, you cannot see it. Okay, so mouse is better. So basically, أي ما مشكلة. هذه هاي عود. Okay. والله على بالي عود شيء. Okay, so we have the cortical bone, the beginning of it, and then we have the trabecular inside. So the properties of trabecular bone will be 20% of bone mass, replaced every 3 to 4 years, found on the inside of the bones, and provides strength and elasticity. This is the site of mode of action of certain drugs like bisphosphonates, the most commonly used drugs, and also denosumab. Just a reminder to you. So trabecular bone showing its honeycomb-like structure. So we have also, where is that? This is the cortical bone, sorry, the outside one. 80% of the bone mass, outer surface of the bone, withstands mechanical stress. It's replaced every 10 years. Defined a bone structure or shape, attachment site for muscle or tendon, the outside. It's a site for mode of action with certain drugs as well. Basically, the cortical bone, they look dense, smooth, and uniform in structure. So there are 3 major cell types in bone: osteoclast, osteoblast, and osteocytes. Osteoclasts create saucer-shaped cavities in trabecular bone and tunnels in cortical bone resorption. The osteoblast, they are related to bone formation. Bone formation regulates calcium and phosphate levels between blood and bone. The osteocytes, think of them as retired. So osteoblasts that no longer form bone, they are retired osteoblasts. They are involved in regulation of bone remodeling. So basically, our main focus here is osteoclast and osteoblast. Clast is the one that eats up the bone, bone resorption, and the blast is actually the one with building. Blast, building. So in many instances that leads to osteoporosis, there is excess of rank L ligand. If you look at this diagram, this is CFU, colony forming unit monocytes. And there is, they start transforming into osteoclast, especially if there is some kind of physiological reaction that is related to rank L or rank ligand that is connected and attached to rank. And there is a balance between the rank and the osteoproterogen, OPG, it's difficult for me even to say it, osteoproterogen. So what happens is that there is some cytokines are released, and then this results in activation of the colony forming unit monocytes, and after some activation they become osteoblast actually, and some of them sometimes they transform into multinucleated osteoclasts. The osteoclasts are good but bad for osteoporosis because once you have activated osteoclast, the bone resorption starts to happen. So the osteoporosis definition is the bone strength. Basically, bone strength depends on bone quality and bone mineral density. The bone quality is related to microstructure, geometry, turnover rate, damage accumulation, and degree of mineralization. The bone mineral density is related to a real bone mineral density, here measured by gram per centimeter square, and the volumetric BMD is measured by gram to cubic centimeter. So the common sites of fractures in patients with osteoporosis here are the hip, wrist, and vertebrae. But there are obviously other sites, depends on the degree of osteoporosis and the area of trauma. So you can imagine an elderly with the fracture of the backbone or the vertebra, especially the lumbar, or you can imagine an elderly or even young patient with the risk factors that promotes bone resorption that may fall and then fracture the distal radius, and also fracture the femur, the neck of the femur, or trochanteric fracture. So it's a silent epidemic. So 1 in 3 women aged 50 years or more will experience an osteoporotic fracture. So osteoporosis is estimated to affect 200 million women worldwide. The lifetime risk of osteoporosis fracture in men aged 50 years or more is about 27%, which is higher than the risk of prostate cancer. So the voice of osteoporosis epidemic is only 1/3 of vertebral fractures come to clinical attention, and underdiagnosis is a worldwide problem, and up to 80% of patients at high risk for additional osteoporotic fractures are never identified or treated. And patients, when they come to our clinic and say, Dr. Khalid, I think I have fracture, I have actually osteoporosis, and I can tell them, actually, you don't have osteoporosis, because the osteoporosis does not have manifestations unless you have a fracture. So it's a silent disease. It's like silent killer, which is hypertension, unless you have a stroke or something else, or hypertensive crisis with headache and kidney injury. So the fracture begets fracture, and that's a sad fact. So for example, if a patient has a first vertebral fracture, at all BMD values, the risk of new fractures in patients with osteoporosis increases 3 times after the first fracture, and the second fracture then increased 5 times, and then third fracture 8 times. So fracture begets fracture. So many of my patients, unfortunately, are ill-educated, and then I tell them, you must start anti-osteoporotic drugs, and they said, no, I'm fine. Actually, I had this example 2 weeks ago. A woman who came to my clinic, clear fracture, 3 fractures, and she completely refused to take drugs. I don't want to take drugs. I'm happy like that. Like, you don't know the next fracture where it will be, but you have a very high risk of fracture. Disease burden of osteoporosis, hip fractures. Obviously, I remember one of my colleagues, he's a dear friend of mine, actually his father got a fracture in the hip. And in my mind, internal medicine mind, actually I knew that he's most likely gonna die soon. And he did. He died within 6 months. So hip fractures increase death in the first year by 20%. And there's a 30% permanent disability. 40% patients with hip fracture have inability to walk independently. And 80% of them are unable to carry out at least one independent activity of daily living. This is not a joke. You have to convince your patients to start taking responsibility and taking the drugs. And if they are compos mentis, but if they are not with it, then you have to talk to the family and see how else you can prevent fractures. You may involve other allied healthcare professionals like physiotherapy, occupational therapy, and assess the safety of home and all these things. So there are unmet medical needs in osteoporosis. Most women do not receive treatment during the year following an osteoporotic fracture. Almost 50% of patients discontinue their prescribed medication for osteoporosis within 1 year. Poor adherence is associated with increased fracture risk. And we found that not only poor adherence, but during COVID crisis, there was no poor adherence, but there was delay in receiving the medications, whether they are oral bisphosphonates or subcutaneous denosumab given every 6 months or other medications. There was an increased risk of fracture in those patients during COVID crisis. How can we improve outcomes? Increasing osteoporosis awareness and improving diagnosis rates leads to better outcomes. That's why you're here. To listen to us and remind yourself about this osteoporosis business. OP, or osteoporosis, is a silent disease until a fracture occurs. Yet, even with a fracture, osteoporosis is not identified. To increase diagnosis rates, several measures can be introduced. Increased testing and treatment could prevent almost 4 million fractures and save $40 billion. Post-fracture care, or PFC, post-fracture care programs help fragility fracture patients receive fracture risk assessments and treatment according to guidelines, resulting in societal savings. And finally, patients who are persistent on their osteoporosis medications have nearly 30–40% greater decline in fracture rates compared to those who are not persistent. And then we have here that increased osteoporosis diagnosis, treatment initiation, and persistence of therapy through robust clinical care pathways leads to better outcomes. Osteoporosis is a silent disease until a fracture occurs, and I mentioned that already. So we need to increase awareness of osteoporosis and fragility fractures with healthcare professionals and patients. Recognize risk factors early to avoid the first fracture. We need to test BMD when necessary, and there are risk factors and age appropriate. And we have preventive programs for those at risk and facilitate screening. We need to recognize osteoporosis when prescribing with fractures in an early ER setting. Ownership pathway, create ownership in the care pathway, and an integrated strategy for osteoporosis and fragility fracture care. Because management of osteoporosis is fragmented across specialties. We see that in the hospitals. Coordination of care via fracture liaison service or orthogeriatrician services also is an option. But not only orthopedics are the main pathway. Actually, in medicine, people like internal medicine, general medicine, if they are interested, or rheumatology or endocrinology are the main people. But the orthopedics help direct those patients when there is fracture. Healthcare professional engagement in patients' conversations to increase awareness and seriousness of osteoporosis. This is an PFC or post-fracture care program helps fragility fracture patients receive fracture risk assessments and treatment according to guidelines. For example, the patient care pathway in a secondary fracture prevention program starts with a patient with a new fracture presenting, for example, to the emergency department, and an ER or medicine finds out that the patient has a fracture on X-ray. Then you have an orthopedic trauma referral, orthopedics inpatient ward, and then identification of those fracture patients and conduction of assessment. Another pathway after the patient presents to the ER is if this is a minor fracture, then referral to outpatient fracture clinic if it exists. There is communication of management plan to GP or primary care, monitoring of treatment initiation and adherence. Then we also ensure personalized osteoporosis treatment recommendation, false risk assessment, exercise program, and education program. So with all this, there will be enhanced communication between healthcare professionals or HCPs by providing a care pathway for the treatment of fragility fracture patients. A long-term adherence to osteoporosis treatment when initiation performed in the post-fracture care program due to follow-up and renewed of treatment in routine daily practice. And finally, this will result in fewer fracture or refractures, fewer hospitalization, fewer long-term care or nursing home admissions, fewer patients needing caregiver or family support, and finally, fewer caregivers having to give up work productivity or quality of life. Multiple studies show that implementing fracture liaison service can be cost effective or even cost saving to the healthcare systems. So for internists, that's what matters to you. What should I do if I think of osteoporosis? Blood, so anemia may raise suspicion for multiple myeloma, so please ensure that proper testing for anemia, including multiple myeloma. I'm talking about those patients who are in the elderly age. Estimate creatinine clearance, do full LFT, calcium profile, including calcium, magnesium, phosphorus, 25-hydroxy vitamin D, and evaluate for secondary causes. Obviously, you will take some history, but you need to also evaluate PTH. I do PTH, and sometimes I discover undiagnosed hyperparathyroidism. Be careful. So not history is reliable all the time. Again, you rule out multiple myeloma with hemoglobin, serum protein electrophoresis, urine protein electrophoresis, 24-hour urine collection for calcium level to assess hyper or hypocalciuria is consideration. Testosterone and gonadotropin levels in younger men with low bone densities, TSH level if on thyroid replacement, urinary free cortisol level, and test for adrenal hypersecretion. We found some cases in my hospital where actually I was lucky, and I sent the patient after finding some of the hormonal imbalances. I sent the patient to endocrinologist, and we found out the patient had actually Cushing disease causing osteoporosis, and she was young. She was in 36. We do celiac disease if celiac disease is suspected. To be honest, I start to do them more often, even if the patient doesn't endorse history suggested, because sometimes you discover that they do have celiac disease, but they don't understand. Biochemical markers for bone turnover. You have bone formation like bone-specific ALP, Others can do type 1 procollagen, propeptides, and osteocalcin. We don't do it that much. Bone resorption, C, telepeptide, N, telepeptide, and others, which we don't do that much anyway. You do x-rays to assess overall skeletal integrity, can suggest presence of osteopenia or bone loss, but cannot be used to diagnose osteoporosis. Osteopenia is suggested by a cortical width that is less than a medullary width. Lateral spine radiography can be performed in asymptomatic patients in whom vertebral fracture is suspected, in those with height loss in absence of other symptoms, or in those with pain in thoracic or upper lumbar spine. Diagnosis of osteoporosis actually depends on person's age and risk factors identified. DEXA is the only reliable diagnostic test and is used to investigate BMD. X-rays is used to confirm vertebral fractures, and you can use a FRAX. You can Google it. FRAX can be used to identify patients at risk where BMD measurements is not available, and there is Abu Dhabi, so you can go to FRAX and find, especially for the UAE, because the UAE was part of this international validation of the FRAX. So BMD should, this is an important slide. You can take a picture, I don't mind. BMD should be measured at both PA, posterior, anterior, L1 to L4 spine. Many times the technician does L2 to L4. Please just call and yell, start yelling. L1 to L4, period. You need to give me L1, L4. And you need hips, and there should be proper exposure, not rotation. So because wrong readings give you a wrong impression. And that's what happens to many physicians who are not expert in reading DEXA. T-scores define BMD and are used to diagnose osteoporosis. A T-score expresses the difference in standard deviations, or SD, between the patient's BMD and normal mean BMD of young population. So according to WHO classification, -1 or better is normal BMD, -1 to -2.5 is low bone density, and -2.5 or worse means is most likely indicating osteoporosis. Z-score compares an individual's BMD to a population of the same age. For example, WHO diagnostic classification should not be applied to premenopausal women, men less than 50 years, and children. Common rookie mistake, actually executed by physicians and sometimes orthopedics who know nothing about WHO classification. Do not use T-score to premenopausal women, men less than 50, and children. Instead, use Z-score adjusted for ethnicity or race, and Z-score values less than -2.0 SD, or standard deviation, means below the expected range of age, and Z-score more than -2.0 SD means within the expected range of age. Please take a picture of this slide, I don't mind. Diagnosed by FRAX, I told you about the FRAX, and this is how it looks like. The fracture risk assessment tool uses clinical risk factors to calculate the 10-year probability of fracture, and it uses age, sex, BMI, previous low trauma fracture, parental history of hip fracture, current cigarette smoking, steroid use, high alcohol intake, more than 3 units per day, and femoral neck T-score, and presence of rheumatoid arthritis. There is a new modified FRAX, but unfortunately the people who invented that, they want money, so every time you use it, you have to pay them. Sucks, by the way, because it should be free. So to end up, I'll end up by one case and finish because I have a minute and a half. So history, I have a 61-year-old woman living in Dubai. In October 2018, she presented to my clinic with a 3-month history of back pain relating to the right leg, which occurred after lifting her husband, who was admitted with osteoporotic leading to spinal fracture. So the alleviating factor is rest, aggravating factor is walking, cardiac risk factors, hypertension, diabetes, and dyslipidemia. So there is factors for osteoporosis, diabetes, and menopause, but not early menopause. And all other risk factors are negative. So we did blood tests, so ESR 39, hemoglobin A1C 9.2%, uncontrolled, diabetes, low serum phosphorus, but normal labs like CBC, platelets, CRP, creatinine, magnesium, calcium, PTH, LFTs, serum protein electrophoresis, everything. MRI lumbar spine in Dubai, October 2018, showed multiple like disc herniation, degeneration expected for age, but also showed a compression fracture at T12, L5, and L1 and L2, some scoliosis. So this is the X-ray. It shows 50% wedging of the T12 vertebral body. This is what happened when she lifted her husband. This poor woman. So this is the DEXA. It shows a T-score of -2.9, so that's osteoporosis in the lumbar area, but she had osteopenia in the right femur, and left radius, she had osteoporosis if you use the left radius. I used it actually sometimes. So the patient has osteoporosis with the following risk factors: diabetes mellitus and menopause. And of course, now she's having fresh osteoporosis. And we replenished the vitamin D, calcium carbonate, هو الطابوق مالنا دائما نقول المرضى الطابوق هو calcium. So calcium is the building bricks. And we started on teriparatide 20 milligrams subcutaneously. It's an anabolic hormone. And شو خلاص آخر slide. The last slide.
It's not working.
Okay. So that's my last slide actually. And
Thank you very much, Dr. Khalid. We catch you on the last minute.
that's fine actually. Ma.
Question will be at the
physiotherapy,
end,
blah blah blah. Nothing. خلاص. That's
Thank
it.
you, Dr. Khalid. Dr. Shamma.